Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo, and I'm here with my favorite co-host of the evening, Dr. J. Calvert. How are you?
I'm good. Is there another co-host coming? There may be one that's not your favorite, and you're going to be like, you're just not my favorite co-host. You need to hit the road.
For this evening, you're my favorite.
Thank you. I'm happy to be here.
So we're going to go with that.
Yeah, and I'm happy to be talking about what we're talking about because it's an important, near and dear topic for you.
Yes. Today, we are talking about rectus diastasis versus a hernia in the setting of a tummy tuck. So I'm not sure, Sean, how you're going to wrap that up into a cutesy title, but...
Should I do the rectus thing?
What's the rectus thing?
Say rectus.
Rectus.
Rectus damn near killed us.
Oh my gosh. Is like a context that I'm missing?
Oh,
okay.
It's just an old plastic surgery thing from residency. That's
Got
all.
it.
Those who know, and
those who don't are befuddled.
They're befuddled.
Well, a rectus diastasis, fancy
What is
word. That? What is that? What it is. So when you have your abdominal muscles, your six-pack muscles, they're made up of actually... Yes, doctor, your six-pack muscles.
You mean my keg? I don't have a six-pack. I think it's like a little pony keg. It's a little different. I'm working on a six-pack. I'll get there.
The idea is to have a six-pack. No one really has that. A few people have it. But it's those muscles that run longitudinally up and down the center of your abdomen. And it's actually composed of four different muscles. Not important for what we do here, except to know that the name of one of those sets of four muscles is the rectus muscles. And those are the rectus abdominis muscles, to be specific. And so those are the main muscles of your abdomen. They run up and down, and usually they sit right next to each other in the midline. So if you do have a six-pack or you have abdominal definition, you can actually see the two rectus muscles, and usually like a little indentation in between where they are connected, but they don't meet per se. And what's important to know here is that all muscles are covered by what's called fascia. Fascia is a thick connective tissue. It's found throughout the body in various places, and it lies on the surface of muscles. So when you have a rectus diastasis, the muscles themselves, the actual muscle bellies, have separated, but the fascia that covers the surface of them is intact. So that is different than a hernia. A hernia is when you have a separation of the muscles and the fascia that covers them, and that allows for the abdominal contents, the intestines, to actually come out past the muscles and are just kind of living under your skin. That's what a hernia is.
Yeah, hernia and rectus diastasis, easy for me to say, get confused a lot. You can have a rectus diastasis that kind of looks a little, because it's very wide, it can look like it's an actual hernia, but it's not. The fascia is still intact. A hernia is a defect in the fascia where, either the preperitoneal fat, the fat before you get into the abdominal contents, or the abdominal contents themselves, the intestines, whatever, can herniate through there.
Right.
And so when you look at these for people who come in and say, like, I need a tummy tuck, the evaluation starts with how wide is the rectus diastasis, is there an umbilical hernia? Is there a ventral hernia? Is there any kind of hernia that I need to address? Because I find that when there is a hernia, it makes the operation a lot more, it's just higher impact, I guess is the way to look at it, on the patient. They're going to have a little bit more healing to do to fix that hernia.
Right, because you just did the whole podcast.
Well, then we can wrap up and go home. Next, please. No, we didn't.
Right.
We got a lot to talk about.
No, I know, but we got to break it down to its components. You just wrapped it up in one paragraph.
I have a way of doing that. I just and for summary. Oh wait, should we talk about it first?
Should we talk about it? Let's do that.
Let's talk about though how you diagnose the difference between the rectus diastasis, because the patient that comes in with this is the patient who feels like their belly's too protuberant. They've got extra skin. They may or may not have extra skin. It just may be blown out from pregnancy, from having twins. The large babies that have blown out the abdominal wall. That really you need. It's not going to snap back.
Right. Yeah. So let's talk about who gets a rectus diastasis. Not usually, but sometimes it's anyone that's had a baby, particularly as you mentioned, large babies plus a small mom is a setup for rectus diastasis because your abdominal wall can only take so much stretching. And especially if you have a large baby and you yourself are small, or there's been multiple pregnancies, or you've had a twin gestation. So what happens during pregnancy is, baby's going to find a way to make room for itself. And so as a result, the mother's abdomen is stretched out. Those muscles get separated. Sometimes they can get a small umbilical hernia, but usually there's no actual big hernia. The abdominal wall doesn't pop open. But what happens is those muscle bellies themselves separate, and then you just have it covered by the fascia in the middle. And the story I hear classically is, someone's had a baby or they've had twins, and they've done a pretty good job of losing the post-baby weight, but they complain that their stomach still sticks out really far. And sometimes they can be really small women and they still look like they're pregnant. And they think that they have to lose more weight, that they're still overweight. And it's not. It's just that the muscles are so separated and they're not doing their job. Their job is to come close together, tighten up, be a strong, supportive core for the person, and keep all those intra-abdominal contents inside and tight. When you've lost the function and the ability of the muscles to do that, your entire intra-abdominal content sort of just push themselves out, and now you look like you're pregnant, or you have, that distended beer belly. And it's actually, it can be, if it's bad, it can be uncomfortable in the back as well. Like patients will say, I have low back pain because they have zero core support. Those muscles are there, but they are not capable of functioning the way a muscle should. So that's usually what you would see after, babies and pregnancies. You can also get it just from being overweight for a really long time. So
That's true.
if you've had, especially if you're the kind of person that stores their fat in their abdomen, and it can be externally, but a lot of times it's internal, that internal fat that people talk about that's bad for you, that causes diabetes, the fat that's wrapped around your intestines. If you have a lot of internal fat for a long period of time, that's a lot of pressure on your abdomen, kind of like being pregnant. And so it can do the same thing. It can separate the muscles and cause a rectus diastasis.
And I think functionally, you touched on something that's really important. Like, if your muscles are not in the right position, they don't work well.
They don't work well. They're designed to have a certain amount of tension on them, and if they are displaced and in a non-anatomic position, they can't maintain the amount of tension they're supposed to have to do their job.
Yeah, and that's an underrated benefit of having the rectus diastasis repair, which we'll talk about.
Right.
But I think that those are the key points. What's the widest rectus diastasis you've ever seen? And I'm sure you've seen some big ones that you've had to pull out the ruler and wait a second, I got to measure this one.
13, 15 centimeters, something like that.
Yeah, mine was 12. So
Yeah, so to put that, in the imperial formula, 13 centimeters is like 7 inches, something like that.
Yeah, it's
a little less.
Yeah, like 5.5, 6.
Yeah, it's like half a ruler.
Yeah, it is, but it's wide, and
it's wide.
It should be like
a few millimeters,
a centimeter at the most. So you're talking about like half an inch. You're talking about now multiple, 6 inches or whatever.
Right.
It's a very wide position for the muscles to be at, and they should be really close together, just like you see on the washboard stomachs that everybody admires. They're the little six packs are all very close together. They aren't
separated.
5 inches apart,
No,
where
right
there's
next to each
just
other.
skin.
Yeah.
So what we're talking about is those muscles being splayed apart by that much that they can't contract to give you an attractive abdomen. They can't contract to support your back, and they certainly aren't going to give you any kind of washboard stomach. So there's multiple reasons why people want to get their rectus diastasis repaired.
And a rectus diastasis repair is a very classic integral part of a tummy tuck. So you talk about tummy tucks a lot, and for the most part, we talk about the skin that we remove. So after pregnancy or weight loss, the extra skin of the abdomen that's there. We talk about the liposuction that we do to contour the abdomen, and then we kind of just say, oh, and by the way, we repair the muscles. But it's really not an oh, by the way. I mean, the repair of the rectus diastasis in a tummy tuck is super important in the final outcome for the patient, because that is what's going to take you from having a protuberant abdomen that sticks out in space to having basically a flat one. If you're otherwise in pretty good shape and don't have a lot of extra fat, you can get that flat abdomen. But the only way you can get that is if you repair the rectus diastasis. So sometimes I will have patients that come in that they're like, well, I don't want a tummy tuck. I just want liposuction. And I'm like, well, we could do liposuction, but your stomach is still going to stick out in space because we haven't repaired the stomach muscles. So the rectus diastasis repair is really, really huge and critical part of a tummy tuck.
Yeah, and if you do the liposuction, you're going to expose the rectus diastasis even more, which, by the way, I've done that. I have suctioned down somebody's abdomen so nicely. And maybe I just didn't appreciate how splayed they were, and they look a lot better. Do not get me wrong. The liposuction works. It makes their abdomen smaller. You can contour their waist, all those things. But they really need that rectus diastasis repaired to get a beautiful look. Now it's not nothing to do the rectus diastasis repair.
Right.
So let's talk about that a little bit, Dr.
So
Rovelo.
let's go through that. Because in a classic tummy tuck, we do the incision at the bottom of the abdomen, kind of hip to hip, like a big smile, and we elevate all the skin all the way up to the bottom of the breast, to the bottom of the sternum or the breastbone, and we're looking right at your rectus muscles. So it's not easy, but you're looking right at it. So it's an easy place to go ahead and repair the muscles. And we can talk about how we repair them, but basically it's a suture repair. Some surgeons prefer absorbable, some prefer permanent sutures. Most of us do it in a couple of different layers. The idea is that you are literally using sutures to tie the muscles and the fascia back together in the midline. And that is part of doing the tummy tuck, and it's really easy to do when you have the abdomen open like you would for skin removal during a tummy tuck. Where it gets a little bit tricky is if someone doesn't want to do the skin removal or the big incision at the bottom. And there are a few ways that you can repair the rectus diastasis through small, tiny incisions, but it's really hard. It's not great, and it really has to be the right person, because very few people have an isolated rectus diastasis and not any extra skin. Like the pathologies that cause rectus diastasis also usually cause excess skin.
Well, to that point, there was a period of time when I was doing a lot of these rectus diastasis repairs on, women that really didn't need skin repair. They didn't need skin excision. And I called it the Newport abdominoplasty because it's kind of like a Newport Beach thing, like these
little skinny women.
They have a different term for it on social media, but they would have these babies and be back doing their Pilates and doing everything, and they just would have an isolated rectus diastasis. And so there's really no skin to take out, but they really have the muscle issue is significant. And so I would do a modification of the abdominoplasty with a periumbilical, a little around the belly button incision, and then a little bit low abdominal. Usually I'd use their C-section because C-sections are so common in the Southern California area. But if they didn't have it, I would make an incision, and that'd be about 5 or 6 centimeters, and I'd use an endoscope, and not like my little forehead endoscope. I'd use like a laparoscopic, like a big old laparoscopy.
It's a retractor that has a light, and you can put a camera through it, so you can see, through little spaces.
See the diastasis, and then I would use a LAND, long ass needle driver, and I would use that to repair the muscles without undermining. There'd be some undermining of the skin because you need to lay down, but I would use drains back then. Today I would just probably suture it down, but I haven't done those in a long time because they're so hard. They're so hard, and it's really difficult, and people don't want to pay the money for it because it's like it just takes a while. Right. It's hard to do, and so
it's hard to see the positions you have to put your head and your neck to like.
Well, that's why I like the camera, but and that was a play off of an old operation. It's not an old operation; it's one I still do, called the marriage abdominoplasty. That would marry liposuction of the upper abdomen with a mini abdominoplasty down low with rectus diastasis repair down low. Because a lot of times if you would diagnose the upper abdomen as like sort of the muscles are still good up top, because a lot of times when after pregnancy, it's the lower abdomen that gets blown out because of the linea semilunaris, another big term there, which is where the muscles of the abdomen go from 3 layers to 2 layers down in the low abdomen so that you can expand it for pregnancy. That marriage abdominoplasty was great, and I would use the endoscope to do the repair if I had to do the upper part after the liposuction. All very, very complicated, very intricate techniques, and I think now people just want to like get a tummy tuck and be done with it.
Be done with it.
Yeah.
Because when you have this, when you're looking right at it, you have the skin open, the results are going to be fantastic. They're going to look so good. And like I said, small category people that may not need the skin incision. But like you even said, there's usually something in the lower abdomen that you need to take a little bit of.
You do.
So
that's how it is.
That's how you do it with a tummy tuck. Theoretically, you could do it without a tummy tuck on patients that were going through insurance, which I'll touch on briefly, and didn't want a tummy tuck and weren't going to pay for it, and they already had scars. You can just do a big midline incision. Not ideal, not recommended, not an aesthetic procedure.
No.
But if all you're coming in for is you want insurance to pay for your rectus diastasis and you don't care about having a tummy tuck, then one option is to just put a big open cut in the middle.
Oof. That doesn't sound very good.
It doesn't, but there's a population of patients that really don't care, and they just need it fixed. So general surgery way of just going in and fixing the problem and not caring about the aesthetics.
You see, that's the difference. Like, I can't even talk about that. Like, you did general surgery, so you can, like I did 3 years. You did the full Magilla, and I would just, I think I would have tears coming down my eyes while I was doing it. You know,
we have different patients.
I know. Well, you do. That is very true. You do some very, very tough, difficult body operations for patients who really need them.
You really need them. And so that brings us to the topic of insurance, because this comes up a lot. And not in an unfounded way, because when we go through everything we just discussed, all of the problems that you have with rectus diastasis, you can't control your core. You have an impending hernia. Like that fascia is weak. You can get a hernia through it down the road. You have back pain. You have all these real medical issues. And so people always ask, will insurance cover this repair? Short answer, no. Until you have an actual hernia, which is classic insurance, right? Until you have an actual bigger problem, we're not going to cover, the prevention of it. We're not. And I have tried. There was literally, like, every surgery we do comes with what's called a CPT code. And like a breast reduction, 19318. A paniculectomy, 15830. Everything has a code that's associated with a reimbursement from insurance. There is literally no code for rectus diastasis repair. So even just trying to go through the process of requesting authorization is really hard because there's no code for it. Now, if you have a little bit of a hernia, sometimes you can combine the two and get authorization for the umbilical hernia. And while you're there, if you're a nice surgeon, pro bono, do the rectus diastasis. But it's really hard to get the coverage for the rectus diastasis. I have had some people have success by putting through a tummy tuck code, which is interesting because some insurances will approve it. But then you have the patients expecting a tummy tuck. And they're not going to get a tummy tuck, but they don't want to pay the extra money for that. So it's become so complicated that I just say, no, insurance doesn't cover it. And I'm not going to go through all the extra hoops and steps to do it because I know they're not going to cover it. And if they do, they're going to cover like half of what we actually need to do to make this abdomen look good. And I don't want to do a half-assed procedure and not actually, make it all better.
Yeah, I mean, that is the problem. Insurance will confuse situations of plastic surgery more so than making it clear. Don't you think?
It's so confusing. And that's the other thing too, is that like they will approve, oh yeah, you want to do a tummy tuck code? Sure, you're approved. But then they don't pay for it because there actually is no reimbursement associated with a tummy tuck code.
Right.
A code exists. Yeah, sure, you can do that tummy tuck code, but there's no, work value and therefore no reimbursement associated with it. So thank you for doing all that work for free, but we're not going to pay you.
Yeah, and then the patients get angry because they said, but my insurance approved it.
Right.
They didn't say how much they were going to pay. They simply approved the fact that you, as the surgeon, have asked permission from the insurance to do a tummy tuck on their insurance. Yes, you can do it. We pay zero for that.
Right. That's basically what it comes down to.
And that to me is genius on their part.
Yes.
And that's the that is where you just I don't know. I don't know what the answer is with these insurance companies. I don't know what the answer is for the patients because the patients become confused and they get angry.
Mm-hmm.
And they get angry at you like you run the insurance company. Like if I ran the insurance company, I would have patients, get coverage for their operations, and in that the operations would get paid for.
Yeah.
That's not the case. And so it is it becomes really confusing. You get a lot of angry people.
Right. So the short answer to that is, does insurance cover repair of rectus diastasis? Not really, and expect to pay for it unless you have a true hernia. Which brings me to the topic of hernias with tummy tucks, because I've had this come up a couple times recently. A hernia, like we mentioned, is when there is an actual break in the fascia and the intestines or some of the intestinal contents are coming through that break. And classically, the repair for that is you close up the defect, plus minus, depending on how big the defect is, put a piece of mesh into it. And so that is something that can be done. If it's a larger hernia, I will do it in combination with a general surgeon if it's going to need a mesh or something like that, because I don't want to deal with mesh in the abdomen. That's a whole nother thing. I don't want the responsibility for that. So mesh, if it requires mesh, I bring a general surgeon in to do it with me. The only time I don't like doing that is if it's an umbilical hernia, if it's a hernia that involves the stalk of the belly button. Because when we do a tummy tuck, you actually cut all the way around the belly button and you leave it attached by its stalk, which is the connection to the abdominal wall. And the only thing keeping the belly button alive is that stalk. It has blood vessels running up through it coming from the abdominal wall. And that's usually enough. But if you have a hernia of decent size attached to that umbilical stalk and you start stripping the hernia away and off of the stalk, which you have to do to be able to repair it, you've now taken away half of the blood supply that you left behind to supply your belly button. And I've seen it die, and I've had issues with that. So if it's a decent-sized hernia repair, I just tell them, go get it fixed with general surgery. They'll make a tiny incision above your belly button. You won't see it. They'll fix it. Come back to me in 6 months, and we'll do the tummy tuck. And then I won't even have to worry about that hernia, and I won't have to worry about losing the blood supply to the belly button.
Yeah, those belly buttons, they take some abuse when you do those umbilical hernias.
They do.
And especially you've cut all the way around the
skin of the belly button.
It's like,
how do you expect it to survive?
It's not going to.
It's not going to. So if it's a really small one, you can sort of just dunk it and not strip it off the umbilical stalk and put some sutures over it. But if it's anything sizable, I prefer to just have general surgery, repair it, do their thing, and then send them back to me once it's fixed.
Yeah, and they can be repaired laparoscopically, but that makes a bunch of new scars on the abdomen, and that's sort of defeating the whole purpose of why we're trying to do the abdominoplasty, which is to look great.
Right. So that was my little spiel on hernias with tummy tucks. And then I think lastly, the last thing I want to mention, sort of in the context of rectus diastasis, is the massive rectus diastasis, which we talked about a little bit, like, how big have you seen? When they are really large, sometimes I will actually do additional measures to reinforce the repair. I know I just sort of said I didn't like to use mesh, but in this case, I actually do put mesh on top of the rectus abdominis muscle. So the mesh is an absorbable mesh. It's not something that's going to stick around long term, although there is a lightweight version of a Prolene mesh that I like, which actually is permanent, but it's very, very lightweight. But what it does is I do my repair, I bring the muscles back in the midline, and then I lay the mesh on top of it. And that just gives one extra connective tissue layer that would have to be separated for the rectus diastasis to recur.
Well, and I think that's a good idea in those cases because they are just so wide.
They're so big.
It's like...
And I've actually, in a really big cases, put mesh under the muscles. So not inside the abdomen. I leave the abdomen covered with the posterior fascia, but I put a piece of mesh between the posterior surface of the rectus muscles, the back of the muscles, as an additional reinforcement layer. So if it's really bad and you look like you're having a triplet gestation 10 months in, you might be someone that needs one of these more complex reconstructions. But again, the problem, no one's going to pay for it. Insurance is not going to cover it. And when you're talking about something that big and involved, it's a lot.
Yeah, I mean, these are expensive operations. We are not shy about explaining that surgery costs a lot of money. It's a lot to deliver. It doesn't all go to our pockets. Everyone thinks like we're making billions of dollars over here. We're not. It's very expensive to deliver the care that we deliver. It is the meshes cost money. The sutures cost money.
The OR,
everything.
the
The OR. We
anesthesia.
have a tech.
Yeah.
We have a nurse. These operations are expensive.
Yeah.
And in the world of inflation and what's going on lately with the economics of our country, it has really gotten
It's skyrocketing.
It is. It has gotten so expensive, and the medical industry has taken probably 5 extra leaps forward on the inflation thing, because I think people know we can't do it without these materials, and so they just the gouging, I think, has not settled in medicine at all. It is still rampant, and it's made it, and unfortunately the patients have to pay for it.
That's it. But if you do pay for it, you can get a great result.
You can. And I mean, your work's amazing. It's beautiful. You do stuff that is like, it's next level. And I know that you combine lots of techniques. There's, we talked about this today. I was talking with a good friend of mine who's a plastic surgeon, and I was trying to explain to them, what can happen in a rhinoplasty, and because that's something I do a lot of. And it's the same with you. It's like you can get from, here to New York City a lot of different ways. And if you choose to fly to New York City, there's a lot of ways you can fly. You can fly on some economic airline in an economy seat, and you can do some sort of price line, something or other, and you will get to New York City, and it might cost you hundreds of dollars. Or you can fly first class on an airline that is of your choosing and have a very different experience getting to New York City. Or you can fly a private jet. At the end of the day, you've gotten to New York City. But how you got there, the safety of how you got there, how you feel about the result of you getting there are all very different things. And the cost of those different ways to get to New York City is on the order of thousands of a 1,000-fold difference.
Right.
And so when patients are considering who you call to do this stuff, you have to recognize that price does matter. There's a real difference in the way that certain care is delivered. And I don't mean to harp on that a lot, but I do, because I think that a lot of times when you go for low cost performers, then you might find a diamond in the rough, somebody that's coming up, somebody new, and they're really good, and they just aren't charging a lot. But if you want to stack the cards in your favor, chances are somebody with loads of experience with this stuff, who is unfortunately for your wallet a little more expensive, but in the end it probably pays for itself. And that is the truth. I've had patients say that, when you gave me this price quote for this revision rhinoplasty, I couldn't believe how much it was. It was so expensive. And now that I've gotten the result, I would pay for this every single time over and over again. And that's because they got what they were coming for. So it is, and it's not that it has to be expensive to be good. It's just, you have to consider who's doing it, the results, all of that. And that's why we talk about it, because it's a real factor in plastic surgery.
It's a really big one. And it matters. It definitely matters. And these surgeries, a lot of the surgeries we do, all the surgeries we do, it's not, oh, just a tummy tuck today. It's not, oh, I'm just doing a rhinoplasty today. Every single one of these surgeries comes with thought and has real complications. And it's not just, and nothing is just a simple, oh, just this kind of surgery. We actually learned that in general surgery. It's never just a gallbladder. Like if you walk into an OR in general surgery saying, oh, I'm just taking out a gallbladder today, you don't know what you're doing, because things can go sideways in a gallbladder so quickly.
Yes, they can.
And what is the most common routine procedure in general surgery can become a nightmare. And it's the same with any specialty. And so I think you and I both go into our surgeries knowing that this is not just a tummy tuck today, or this is not just a rhinoplasty. There's thought and there's care. And that's what we try and deliver.
And look for the surgeons that are going to do the same for you.
Yes. Well, that is the long and short of it, of the rectus diastasis and the hernia repairs and how they combine with tummy tucks. And without any further ado, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.